Welcome to the Deep Dive, your shortcut to being genuinely well-informed. Today, we're really cutting through the noise to bring you insights that are immediately actionable for you as a general practitioner.
That's right. We've sifted through quite a stack of sources.
Yeah, to extract those critical nuggets you'll use daily. Ever wondered if, a sharp clinical eye can actually be more powerful than an MRI for an Achilles rupture?
Or how the latest DVT guidelines can perhaps simplify those complex decisions you face.
Exactly. And what's the one critical dosing error for methotrexate every GP must avoid? We're going to unpack all of this. Okay, let's dive in.
Our goal for you today is really confidence. We're focusing on what's most practical, most directly applicable from the latest guidance, so you can confidently navigate common yet often complex presentations in your primary care practice.
I appreciate that focus. Let's kick things off with acute musculoskeletal injuries, a frequent visitor to our clinics, right?
Absolutely.
We're zeroing in on Achilles tendon ruptures and ACL tears. Knowing how to diagnose and sort of initially manage these is truly essential.
Definitely. For an Achilles tendon rupture, the patient's story is often quite distinctive. They'll frequently describe a loud pop in the ankle.
Right, the pop.
Yeah, and a common striking detail is that feeling of being kicked from behind, even when, no one was there. Immediate pain, swelling, difficulty walking. That's all pretty typical.
And when it comes to the physical exam, what's our most reliable diagnostic tool, at the primary care level?
The Thompson test is paramount here. It's remarkably sensitive, 0.96, and specific 0.93.
That's really high.
It is. And a positive test is simple. You squeeze the calf muscle and the foot just does not plantar flex. That's your definitive sign.
Okay.
Another highly useful finding is a palpable gap or defect in the tendon itself, especially when you compare it to the uninjured leg.
Mm-hmm.
While other tests exist, like assessing plantar flexion strength, acute pain often makes them, difficult to perform accurately.
That makes sense. And imaging, always a big question. When do we really need an X-ray, MRI, or ultrasound for an Achilles rupture?
Well, if there's no burning tenderness, radiographs are generally unnecessary.
Yeah.
What's particularly interesting from the AAOS guideline
Yeah.
is that they note recommendations for or against routine MRI or ultrasound are actually inconclusive if your physical examination strongly indicates a rupture.
So our clinical exam really holds weight.
It really does. If you have two consistent clinical findings, say a positive Thompson and a palpable defect, further imaging might not be immediately required. You can trust your hands and eyes first.
That's empowering. So we can trust our hands and eyes first. Once we suspect a rupture, what's the current thinking on treatment, particularly that surgical versus non-surgical debate?
Both surgical and non-surgical approaches show satisfactory results, actually. The AAOS recommendations are weak for either.
Okay.
Non-surgical management often has lower complication rates. However, surgery can offer benefits like a potentially faster recovery, quicker return to sports, and a lower re-rupture rate.
That's where patient selection becomes crucial for us when counseling. Who makes a good candidate for surgery, and who should we maybe approach with more caution?
Good question. Typically, younger, active, non-smoking patients with no significant medical history are good candidates.
Right.
We advise caution, though, for patients with diabetes, neuropathy, immunocompromised states, those over 65, individuals with peripheral vascular disease, dermatologic disorders, a sedentary lifestyle, or obesity. It's really about carefully weighing the potential benefits against the